Oh, and I wanted to take a quick second and chat a minute about some of the things that I saw as a common theme in your papers. And by the way, I've enjoyed reading all of your papers. There are a handful left to finish up, but wanted to take a second and share. Many of you chose sort of one of three topics. A good number of you chose defensive medicine. Another group talked about access, and then sort of complexity of pricing. And I wanted to take a minute to make sure that we understood a few themes, and I've talked about this in other videos, but wanted to emphasize it a little bit and recognize that as we look at the healthcare landscape, you got to think about things that everything is connected to everything else. When there's a yin, there's a yang. When there's a pull, there's a push. And if you, as many of you have asserted, you want to lower the cost of healthcare, what that has done in the economic terms is it actually is taking money, resources, outputs from one group and shifting it to another. A great example is us as PAs. Many of you talked about supply of physicians in one respect, and ironically failed to mention the supply of PAs and NPs and the fact that we need to be included in the workforce data in a more purposeful way. But if you take the salary that PAs and NPs enjoy, we are often paid more than the physicians all across the world. So are we willing to take a pay cut in order to make healthcare more affordable? Because what we talked about, and I mentioned in an earlier video about the cost of insurance and the fact that if you compare insurance to the per capita healthcare spending per American, you can see how the numbers are very difficult to make out. But when you look at the cost of care, that can mean something differently to each person. Is it the cost that I have to pay out of pocket? Is it the cost that my employer pays on my behalf? Or is it the 100% cost that I endure? So when we say cost of care, what do we mean? Because the healthcare system in America actually takes the consumer or the patient out, there are many people negotiating on our behalf and may or may not have our best interest at heart. We have some patients that don't care what the care would cost if it doesn't cost them any money out of pocket. Does that make a lot of sense? And so, cost of care needs to be defined when we speak of it. Do we mean fully burdened cost? Do we mean cost to the patient? Because many have talked about with the recent news about Medicare for all and the fact that there are so many people being bankrupted by healthcare cost. Are these people with insurance, without insurance? Is it because of their cost share? Is it because they lacked insurance when they could have had it in some other way and chose to not pay premiums? So the whole point about it is that cost of care can mean many things, and precision, and when we talk about that, is important. The price of care is something different, where there could be some market forces in play with respect to price. The example that I like to use is a healthcare insurance company goes into a particular market. They want to hire a pediatric gastroenterologist, and there's only one of them in the market, but they have to have one for their marketplace. That gastroenterologist, that pediatric gastroenterologist, can actually make and say, I'm not going to accept the rates that you're going to pay me with respect to my services, or the price of his services are in fact higher and he can get more for them because of the economic laws of supply and demand. So price can mean many different things. The price that a pharmaceutical company chooses to sell a product for, that's the price, has nothing to do with cost. So when we look at the cost of care, how does that compare to the price of care? So cost and price are some different things. The other issue that came up a lot that was being used in the papers was consumption and demand. So first off, demand is the desire for a service or a product. I would like to get it. But if it's a certain price or cost point, they are not willing to pursue it because it will either cost them too much or the price is too high. So they demand it but do not have access to it. For healthcare, many have talked about healthcare being a right. And if healthcare is a right, supply and demand do not really make a place or have a place in what we're talking about, except for the extent of those of us as providers or companies who want to enter the healthcare marketplace for a profit or return. So consumption is the use of a service. Consumption of a service is how much you are going to take of the finished service or resource. And that may or may not have a connection to cost and or price. As I've mentioned, if a person is not paying for it, do they care how much they consume as they sit up to the buffet of healthcare services? Demand, I've mentioned. Access to care. Again, access to care has to be defined, in my humble opinion, as to, is it on the terms of an American access to care, or is it the term on what's acceptable? Let's take the Kaiser Permanente system, or even the military. They have had different access standards to certain services, specialty services, MRI, that are more lengthy with respect to when you can get it done. And in the military, we tend to accept those timelines. In Kaiser Permanente, you tend to accept those timelines because of their premium and cost, out-of-pocket cost of the care is very reasonable, and they have fantastic outcomes in the Kaiser Permanente system. So again, access has a component of preference. And there's an American exceptionalism with respect to when we want things and how much we want things and what we want. Is the American ethos in pursuit of liberty willing to put up with the access that would be required to lower the cost of care or bend the cost curve? And that is a big issue. Lastly, we talk about supply, and much of this evolves around primary care providers. Are primary care providers, are there enough of them? Are there enough PAs going into primary care? Why are we tending to lean still towards specialties? Again, we talk about the cost of care in a large altruistic manner, but are we willing to make the sacrifices by putting more PAs or mandating more PAs in primary care? Something to think about. But remember that when you look at healthcare as an industry, if you think of the economy as a pie, and you have the choice between fighting over the slices of the pie or growing the size of the pie from a 12-inch pizza to a 16-inch pizza, and then arguing about the slices at that point. Many would say that you want to grow the economy so that you grow the pie and that you have more to share, if you will. The downside by some is that it's going to make many people or some people wealthy or more enumerated as you grow the pie. So again, there are theories that remember that government spending, government actions do not commonly grow the gross domestic product or grow the pie. That requires expansion either because of a technology change or a change in consumption where the people who are purchasing are better enumerated. So again, some great stuff going on. I want to take a minute to talk about that. The last little sort of thing I wanted to share is really the malpractice and so it goes. Many of you talked about malpractice being an issue, but it was hard except for a handful of you talking about how big is this number. We have this idea in our heads in our practice about defensive medicine, but the numbers, as you all have seen for those that wrote about it, have been between 46 billion to as high as 850 billion. That is a magnificent range. And if we're talking about 500 billion, 800 billion, nearly $1 trillion, that's becoming significant. But when we're talking 50 billion as far as defensive medicine, could we ever bring it to zero? And when you have a denominator of that low amount, is that really going to be impactful? And again, as I mentioned earlier, if you change one part of our resource from the lawyers, the malpractice carriers, and you shift the wealth to another part of the sector, are we willing to accept that change if you were the one losing versus the one gaining with what goes on? Remember, everything is connected to everything else. And the fundamental issue as we talk about the cost of care deal with two fundamental things. One, are all of us in the healthcare industry willing to take less for the service we provide? PAs, pharmaceutical, durable medical, hospitals, are we willing to take less for what we provide? Because the price of our care is actually much higher than others in the world, fundamentally because of the inputs or the resources to our care. No other country in the world pay pharmacists, MRI techs, PAs, NPs, nurses what we do. The cost of our inputs are so much higher. So are we willing to reduce the cost of our inputs in order to reduce the cost of care? The other concept that we have to look at is when you consider the way we access care. At some point, we're going to have to make the hard decision, like other economies and systems, that don't provide certain chemotherapy drugs for the third time. They don't do certain heroics with respect to healthcare. Are Americans, based upon our American exceptionalism, and we really are unique. And when we compare the healthcare markets, we want to make sure that we understand, do they take into account the views that we have as Americans? Are we really willing to make those hard choices that many other countries have made in order to bring that cost down to the 4,000 or 5,000 per capita per year? So when all this being said, what we as a country have said with respect to our healthcare is we have been okay with allocating wealth based upon the consumption of healthcare at the tune of $10,000 per person per year. And that has been sort of an acceptable manner of allocating wealth, sending many kids to college, building many pools and backyards, and giving PAs the wonderful compensation that we have. So I am here really, and I want to close to say, my gosh, am I talking my agenda or my propaganda? The answer is no. I am just trying to provide a counterpoint to much of what was being said in your papers. A counterpoint to say, in order to make your most compelling argument, we have to face the opposing view. And I'm just throwing that out there as far as what some would say about healthcare and about how the system is put together. So again, I would encourage you to continue the great work that you're doing. I appreciate any feedback you might have with respect to this sort of longer than anticipated video. But again, great job, and hope to see more great work from you with the upcoming projects as we roll forward. Keep it up. Talk to you all soon. Be safe.